Epidemiology comes from two Greek words. Epi means upon, and demos, which is the people. So it's upon the peoples. What's going on with the people? And that's when we talk about. I mean, it's not only just infectious epidemiology, but it's epidemiology with all kinds of things. And you can go to places like WHO, CDC, yada yada, to get different kinds of epidemiology conditions, whether it's car wrecks or gunshot wounds or whatever. I mean, all this data gets collected and looks at and tries to look at what's going on. Maybe how can we improve conditions or decrease some of the things that are going on. So the official definition of this is the distribution determinants of health-related states among specified populations and the application of that study to control health problems. That's a lot to say, but it's basically how do we keep people healthy? And how do you recognize that something's going on? And then what can you do? So you first have to be cognizant of what's going on. If you're never probably going to recognize that first episode as being the first episode unless it's something that's just really unusual. And you may or may not get it, like the last case. I mean, we still don't know what happened with the transverse myelitis. We have maybe some ideas, but so we don't have a firm test. But the second and third one should give you the chance of you figuring out what it's going to be. And that's one of the things that we talk about, as you can see, with all kinds of things, especially in healthcare systems. If we were to have a biological agent released, and in my brain, I mean, if I was a terrorist, which I'm not, and sure that's in the record, what would you do? I mean, realistically, when it caused terror, what would you do? You'd wait for something horrendous like the fires, out in California, or getting hit by 2 hurricanes when the healthcare system is somewhat hobbled, in different parts of, and then you let something go. I mean, that would be, bad news for all of us. We all would be in the hospital trying to take care of things. Can you imagine if COVID hit all at once? I mean, it would just be horrid. So those are the things that we want to make sure that we can pick up. And there are different ways of doing it. I'm going to talk about today different surveillance things that go on through emergency departments. But this is, what we do for the hospital. And I also put at the bottom line down there, who cares? Those people care, especially the patients care, because they don't want things happening. And it may be as mundane as MRSA, and looking at those rates or bacteremias and, all the other things that we do look at. So what are the opportunities to prevent them? Looking at what we generally do in the hospital, you all should know this, prevent transmissions among persons, prevent infection from devices. I saw this and I stole it from Sanjay Singh a long time ago at a meeting I was at. He was talking about Foley catheters and it blue screen like this and huge letters. It has WTF. and everybody started snickering and laughing and he goes, what? It's why the Foley. He was talking about Foleys. And I thought, I really like this. So I would credit Dr. Sanjay Singh. And then obviously other lines and devices, if they don't need them, take them out. Diarrhea, C. diff, norovirus, which we're starting to see a lot of norovirus, unfortunately, and other things. Airborne conditions, MDROs, we all deal with that because they're difficult to treat. I always like it, as we go along in medicine, we rename things, right? Of course, the taxonomists rename everything. And I wish that they would get sent elsewhere because it takes me enough time to learn things. And then when they change it to things that I don't remember, when you get old, you have sometimes problems remembering things. And then they change it to things that are just all consonants with no vowels, or all vowels and no consonants. You go, why can't we just say it was what it was? And that actually was with C. diff. That was Sid Feingold. One of the things he did before he died was to get the taxonomists not to call it Peptoclostridium, because it would have changed everything, right? We wouldn't have had C. diff, CDI, CDAD. We would have had P. diff, PDAD. It almost sounds like P. Diddy, but it's different. So he said, no, this is crazy. You put it in this other genus, which is the, what now? The Clostridioides, and Oides is like, and there was only one other genus in that, and it wasn't a human pathogen. And they said, oh, okay, whatever. So that's what Sid did for us, was to keep it, we didn't have to train everybody for the next 20 years. And obviously surgical associated infections. Dr. Ayler knows this quite well because he's been there. He was seen actually with a car lug wrench trying to pump water from it, right? Just to see if there was still, could be still stuff there like cholera. But this was the big thing that, really kind of started epidemiology, was the father of infection control, who was John Snow, or at least felt to be that. And so then I think you sent me that pump picture.
Yeah, it got moved and it's right in front of the pub now.
Yeah, yeah.
And I took a bazillion pictures in front of it last summer. So
Yeah. That may or may not be yours, but so they do have.
That's just
It's a figurehead.
Figurehead. It's not a real pump, obviously.
No. So this happened because of cholera outbreaks in England, and it was really interesting because he wanted to know what the heck is going on with this. Get all these people with cholera, but it does seem to be in certain areas. So he started looking, and they demonstrated that from the Broad Street pump that you could find cholera in the water. And in his fashion, of course, you deal with politicians. Yes, we'll deal with it. So he dealt with it. He took the handle off the pump. It's hard to get water to pump without a handle on it in the old days of trying to force it up the tube. So it was really interesting when you look at what he looked at was the old maps, and then looking at what the water supply was. And he noticed that there seemed to be this concentration in these areas where you see, does this work? Not on there, it doesn't. That's okay. So, but if you see all the little black areas, and Broad Street is right there, and that was where the pump used to be. You see other pumps that were around, and some were kind of associated, but when he looked at this and found that people were getting it and then taking it back to their places of residency or pubs or whatever, and that seemed to be the epicenter of it. So when he stopped that, it really stopped a lot of the cholera epidemic. So now we're going to talk about outbreak investigations, because you all need to know this. At some point, somebody's going to say, hey, you're an ID guy, right? Or girl. I think we have an outbreak. Please look into it and fix it. Talk to you tomorrow. Has that happened? Oh, yeah. We haven't perceived what we think. Sometimes it's real, sometimes it's not. So that's the first thing. Are you really having an outbreak? Or somebody just think you're having an outbreak? So if you are, what are the signs and symptoms of having an infectious outbreak? So is it increasing over a period of time in an area, like you saw with, Broad Street, or in an age group? Is it just in one area, like we're talking about with, having a transverse myelitis or other conditions due to which viruses in kids that we see? Mentioning it. Enterovirus, sure. Like D68 and stuff. So the first go around, people weren't quite so sure, but then when it happened again, and they really started looking, no, we think it's real. We think this is going on. And why does it happen just to some kids? That's what the point is. Is there something going on in these kids that makes them susceptible? We don't know. So, you're looking through all these things that we normally would look through. I don't plan on reading all this to you. I do think that most of you in this room have that ability, so I'm not going to insult your intelligence. But then you want to find out how many cases are there. First, 1 or 2 cases, and you don't know what's going on, and they seem to be different, or, one's up in Broward County and the other one's, or down in Broward County, the other one's up in Jacksonville. I mean, are they really related? Did they travel? I mean, that's what you're going to ask, but are they really related? Whereas if you have 10,000 and they're scattered around Florida, there must be something going on. So think of it as the 5 W's. It's the who, what, where, the when, and why as you go on, and those are going to become important. So step 2, you need a case definition of the outbreak. So what is it, so that you can follow it? Sometimes you just get a lab test. But if it's a new disease, like we just went through in 2020 with SARS-CoV-2, they have different data. We didn't have tests for it really well, although that came about fairly quickly. But usually it's a lot of what we do is we're really good, diagnosticians for the most part. I mean, who cuts and pastes our notes into theirs? Everyone. So, I mean, how much of a surgery note do you cut and paste?
Job reports.
Yeah.
Not even that.
And that's no offense to them, but it's just, so what we need, what we look for is probably more than most people are thinking about, especially with something like this. So, you need to see if there's anything that's common, like we talked about, any of these things, age, race, ethnicity, locations, occupation, underlying medical conditions. If it's just something that happens, with people who have type 2 diabetes, but it seems to exclude everybody else, what the hell's going on with that? I mean, now is it, something they inject? Is it some medication? Is it something else? Why are they getting an infection because of type 2 diabetes? Is it an exposure? I mean, all kinds of questions that you would think about, whether they're right or not, but you have to just open up and think of what could it be, like we're always doing with these cases. What's your syndromic definition of what's going on with the patient, and what's the differential? So it starts out, maybe you don't get everybody, you don't want to miss anybody, but it's kind of hard because you have to have a broad enough definition not to miss anybody. And sometimes you're picking up stuff that probably isn't going to help you. Then you can restrict things. Once you start finding people that really kind of fall into this and are very similar. And that's what happened with COVID, because it started out very general because it was a type of pneumonia. We didn't know what was going on. And then it got broadened when we had better diagnostic testing, and we saw what happened to people, including myself back in 2020. They tell you that if you really want to know a disease, you have to experience it on your own. So are you looking forward to getting COVID this year? You should get vaccinated. Don't get it. Trust me. It's not worth it. I was mean enough it couldn't kill me, so that was good.
Same.
So that's what we're doing. And then once you can get a lab test, if you come up against something, I'm just going to tell you this, it's not any outbreak, but if there's something and you think you're seeing more than one, talk to the lab and tell them you want to draw 2 of serum and you want to freeze it. And then you want to follow these people along, usually around 2 to 4 weeks later, draw another 2. And you want to start thinking about what could it be. Now you have paired sera to see if you get an increase. That's what we used to do in the old days. It still works for some things that we don't know what's going on. And it might give them a better idea of what kind of tests maybe they want to send it out for if we're not thinking about it, or they don't have it in-house. TGH has got a lot of esoteric testing that they're probably better than here, although that may be recent. So step 3 with all this is get a clue. As everyone has told me when I was in training, I would tell you have to get a clue. What's going on? So this is, as who told me this a long time ago, it's like throwing darts. You're trying to hit the bullseye. You don't know what you're doing, so you see if you can hit the bullseye. So you had the hypothesis. What do you think is going on? You're looking through literature. Now I'm not saying to do it, but you could even ask AI. So ask ChatGPT, what do you think's going on? And if it says, why are you asking me a simple question? Obviously it's this, and then you just turn it off and smash yourself. You have to do what we do. You have to talk to people. That's one of the things you can always tell people, the 3 things in ID. Okay. So you have to learn how to talk to people for a variety of reasons. And then what else? And yes, have fun is one of them, but learn ID. So that's the 3 things that I would tell people. But you have to listen to people. And sometimes they'll tell you things maybe they haven't told anybody else, or a family member. Yeah, well, he didn't tell you that he went up to, Alaska and he was eating bear meat and other things. And well, maybe that's why he's got this cystic looking lesion in his lung. So, the dead crows of West Nile in New York City. Unfortunately, Tony Fauci didn't do well from that for a while. The rodents with HPS and Hep C, who went to this was actually a fairly large breakout that happened out in Las Vegas years ago, where there was a clinic who was giving injections and they were reusing a multi-use bottle, and they were using the same. Yeah, to save money. Yeah, not after getting sued for multiple millions of dollars.
Could you go back to that slide?
Sure.
And Sherlock Holmes,
Yes.
plied his trade on Baker Street within walking distance of Broad Street, where Jon Snow plied his trade. Coincidence? I think not.
Yes. Fictional
It all
character.
came together.
Fictional character, perhaps. Sure. I mean, that's when you look at the author, and that's the area. And he was very interested, in a lot of things that were going on in investigation. Of course, that's one of the things that he brought out with Sherlock Holmes. And then who does he have for his less than agile sidekick? So it was who? It was a physician, wasn't it? Yes. So he kind of didn't, he liked the non-physician better than he did the physicians. Anyway, that's a little bit different. We won't go into analysis of literature at this point. So the leap of faith is, okay, you think you know what's going on, let's see if it works. So the science portion, what's causing it, or is it poison? That happens. It's happened in hospitals where they've had people who come in and people don't get a diagnosis because they're sick. They have abdominal pain or diarrhea or nausea, vomiting. We can't figure it out. We order all these tests and stuff. But most people now are starting to think that, could this be somebody trying to off someone for a secondary gain? And so we start looking for things like that. And yeah, I do watch some shows, and it's my girls who are now fully adults, being 40 and 30, almost 37 in a month. I just couldn't do it because I'd ruin it for them because it's got strychnine. How do you know that? Or arsenic or something else, or thallium. The thallium ones were always good. Those are usually associated with travel to Russia or in some other things, being stuck with an umbrella with a little pellet that had it in there. Lots of things that we have to think about. And it may be that we need a toxicologist to think about, some of these. So you need to do the case-controlled investigations, looking at ill and non-ill people. What's the difference? What's going on? Remember, it wasn't that long ago. It still continues to be issues with acanthamoeba keratitis. That they saw some people who were getting it in their eye and other people who weren't. And they were looking at people who wore contact lenses and people that, some that also wore contact lenses, but other people who didn't. And what's the difference? Well, they found out that there was one brand of cleaning and soaking solution that was involved. And that's why some people that were contact lens users had it, some that were contact lens users who didn't. And they got down to, what do you use to clean them? What do you use to soak them? And they found that, one that got it's just the strychnine. So, it can take, this isn't going to happen overnight. This is going to take a while to go through this. So then you take action. So identifying the risk factors so that you can try and put preventative measures in effect. Maybe an easy fix, like recalling a product, or maybe more difficult. I think it's allergic to someone in this room. Maybe a long-term change, like what we're doing now with oxypap, trying to prevent some of the STIs, which might be working so far. And I think that we just have to really watch and make sure that we don't have issues with doxycycline. Smoke cessation, prevent lung cancer, all kinds of things. The other thing that you should be familiar with, and if not, you're going to have to learn how to construct an epicurve. It's just a visual display of what's been going on with an illness. You saw tons of these during COVID, right? I mean, you see all these things, and flu season, and all the other ones. I would send them out. I've been a little lax this year. I meant to pull it up at the end of the year, but I did not, with all the other viral infections we can have besides COVID. So when we do our respiratory viral panel, what do we pick up? And it's really limited. It's just kind of a snapshot of what comes into the ED. And some things that get admitted who don't get diagnosed until they already get admitted. So these are things to look at, and gives you, an idea of when did it seem to start, when did it. Usually this is, we already kind of know what's going on, and then we take action, and we'd like to see this happen. So it's figuring out what's going on, and then trying to fix or prevent that infection or whatever it is, and then watch it go down. So you infer a lot of things from it. You really need to kind of figure out what's going on. So you need to know what's going on at the X and Y axis. Usually the X axis is going to be when did it start, and the duration of it going on, and the Y is the number of cases. So that's really all that we want to do with this. And you see that they're all evenly divided. And of course, the question that I'll answer for you in a little bit is, how do you know the spacing for these days? And it depends on what is the condition or what's the infection. So that's all that we're doing, and this is what it means. And so it should correlate with this. You got one case, you got two cases, so you get two plots. Just to show you the magnitude of what's going on and how it's breaking out. Sometimes you'll see a blip, and then everything looks like it's good, and then boom, it hits again. And then what are we looking at is what happened, when did it get better? Now, why is there now a huge outbreak of this? What population is it in now that we just didn't pick up in the first place, or what is going on? So, the time intervals when we look at this. So once you try and figure out, you know what's going on. Let's say it's an E. coli in an outbreak. So you need to know what the incubation period for the illness is. Some are very short, some are just hours. I mean, if you're thinking about, a food toxin and you want to look at that, I mean, it's already pre-made. So you're going to see that usually within 24 hours, maybe 36. So that time segments may be a little shorter. But what you want to do is put, a quarter, 0.25 of the average incubation period of the illness. So knowing that, you're going to have maybe an E. coli, it's going to take you around 24 hours or so, depending on what's going on, then you could adjust that. If it's something that's longer, then you're going to see it having several days into the interval. So that's what I've done in the past with some of these things, with some of the, respiratory viral pathogens that we have, is trying to put that in 2-week segments. Because if you just put it every day, people just see this little blurb, little oscillation in the background. But once you put it 2 weeks, you can see where it goes up, and then you can see when it goes away. So that's what you need. So if you had an E. coli 0157H7, usually the incubation period is 3 to 4 days. So then if you know that it's 3 to 4 days, and you say, okay, 4 days multiplied by 0.25 is going to be 1 day intervals. So then you can, every day, you're going to plot this out and see how many new cases you have, or is it decreasing and you're having less cases. So the other thing that'd be nice, I mean, you can send this out to people and say, oh, look what I did. I graphed out something. Excellent. What is it? You graphed it. What the hell is it? You need a title. And it can't just say E. coli. Who cares? You really need to have it to say, what it is. Cases of E. coli, 0157H7, by date of onset, and it's in this Epps County in Louisiana, and that was in February 2012. That's CDC had an outbreak, of which that's not the whole thing. But that's what you want, cases of, and then you put in, and then the date, location, time period when it happened. So this is just to have you start thinking about some of this. So there's 7 cases of hepatitis A that's been reported in Homer, Virginia. Construct an epicurve. Please hand it in tomorrow morning for grading. So this is the cases. So you've got 7 cases. There's an age. Interestingly enough, they're all men. And the date of onset is all the age. You see, the earliest was the 13th. The last was the 20th, at least so far. And the date of diagnosis is over here. So what would you use for the x-axis of the epicurve? What do you put in the x-axis? What's the column heading? Which one? Age, sex, date of onset, date of diagnosis.
Date of diagnosis.
The date of onset. Because diagnosis is okay, but you remember you're going to say, when did it start? We ask it all the time. Hi, I've got this respiratory symptom. When did it start? Your best guess. It started 3 days ago at 11 o'clock in the morning. Okay. All right. So that's what we know, and that's what we want, is for the date of onset to be at the bottom. And you see the next one says how many cases. So the average incubation period for hepatitis A is 28 to 30 days. What intervals would you use? Would it be 1 day, 7 days, or 28?
7.
Why do you say 7? Best guess.
This guy's there.
Yeah. So what is it? 0.25, right? A quarter. So if it's going to be, we'll say 28 days, so it should be 7-day intervals, right? 28 times 0.25 is 7. See, you're getting this. You know this. So what's the title going to be for this? Hepatitis A outbreak in Virginia? Oh, okay. That didn't really say much. Homer, outbreak in Homer, Virginia. Outbreak of what? Outbreak of homers in Virginia. Anything was supposed to be homeless in Virginia? Or this, the last one. Well, obviously, you want the last one because you want people to understand what you're showing them. It was an outbreak of what was going on. So from this data here that you see, from the date below, and it's these, the date of onset and date of diagnosis, what's the one that represents the date of onset for case 1? So which one of these would you put this person into? And it's the first case. So guess what? It's the first one. It should be towards this side, right? Okay, so the onset is December 13th. You've already figured out what the intervals are going to be. So if he got this on the 13th, then it's going to not go here, right? Why? Because it's the 13th. We're into the 14th going through the 21st. So these are 7-day intervals, remember? So he's going to have to go here. So that's where the first one goes. Sometimes people forget, they try and lump it ends out, but that's really where it goes. So this is the 5th case. Where's the 5th case go? So the date onset is January 9th. So it's going to be one of these two. So which one? Easy. It's the 14th. So you add it to the top of 14. It's, yes, as they say, it's not, rocket surgery. So you're now an expert epidemiologist. Yay! You can put that on your boards. Say, I graduated. I know what the hell I'm doing now. Guess what? Well, no. You're now an expert. I'm not around. Either Judy or anybody else. It's up to you guys. So the Georgia State Veterinary Conference just ended. You happen to be around in the area, seeing the lights of Georgia, and dozens of people got sick at the conference complaining of severe stomach cramps, diarrhea, and fever. The conference coordinator at the state and called the state health department, who reports that several participants are sick and 2 have been hospitalized. So it's not good. As an outstanding infectious disease practitioner, you're all asked to help with this. So you got to figure out what's going on. So one of the things is to find out, okay, so all these people got sick at this. What was going on? It's a veterinary thing. What's going on? So you call the event coordinator and ask for a schedule of events and a list of conference attendees, because you got to know if people are getting sick, who was there, who potentially got exposed, and what did they get exposed to. So the coordinator asked you to give contact information to the 15 people she knows are sick so far. So you try and call each sick person to interview them and ask about symptoms when they first became sick, which events they attended at the conference, what they ate and drank while they were at the conference, and if they know if anybody else is sick. Since you don't have lab results of anything, you need other information to come up with a hypothesis. All you know is that they're sick, and that you need to know how many people are sick, what are the signs and symptoms, when did it begin, what do the individuals have in common, what events did each one of them go to. Those are the key things you need to. I mean, this is an outbreak at an event, and this is not uncommon. I mean, it's like a cruise ship or something else. It's like, hi, I went to the Bucks game. I was despondent because they lost, but now I'm having nausea, vomiting, and diarrhea. What do you think? You're around all these people who are not washing their hands. And there's a norovirus outbreak going on in the area. Probably. But you need to find out, what did they eat, where were they? And is it foodborne or is it not foodborne? Is it something else? So you got a hold of 10 out of the 15 people to better understand how the attendees got sick. You ask about the activities that they went to, which is a list of things over there, and the foods they ate, where they ate, and the drinks that they had, and other activities that put them at risk. And these are the activities where they were. They attended a tour of the vet clinic, which is one of the things they could do. They went to the opening session, so 6 out of the 10 did that. They attended breakfast reception, 6 out of 10 did that. They attended a welcome party. Everybody, the sick people, went to that. They stayed at a conference hotel, which was 8. So let's not trip over that. So what do you think is the thing that really seemed to, that all of them had in common? It's just like in the, oh gosh, what was it, Monty Python? It was the last movie that they had done. Now I'm going to blank on it.
Meaning of
Yes, the meaning of life. And the one was death. And they all, so what is it? A salmon pate. Killed them all. And of course, as they're going out, and it was an ad lib. Later. He said, "What well, did yet?"
No, one of them said, I didn't have the pate.
I didn't have the pate.
Can I go?
Yes, okay. No, you are still doing. So this is really interesting because all 10 went to that. So you can't have sick people who did these. I mean, they're going to leave some people out. So this one, you're going to probably get the most attention. So, so everybody is getting better, most people. So that's good news. So you're talking to some of the attendees. You'll learn most of them. Met a lot of new people at the welcome party, shook hands, and ate some food. So that's what were you doing while you were there? So, I mean, this is all the stuff we have to collect on this. What were you doing? Meeting new people, you're eating food, you cleaning your hands, all that. So you're shaking hands, you're getting contaminated from God knows who. And based on what they told you, you think it's something that the participants ate because it's making everybody sick. But you need to interview more people so the organizer tells you the food at the welcome party was prepared by a local caterer. You want a copy of the menu that was served at the welcome party to look at to see what might be going on with that. So your initial 10 interviews that you ask about where did they go and what food items that they ate. So now you start looking at coming up with a standard questionnaire, looking at the menu and how many of these people, if you can get a hold of the 75 conference attendees that you hadn't got a hold of yet, to see if they were at the welcome party and what did they eat from this. So now you find these people. You learn that 25 people over the 10 that you know of are sick, including the 10 originals, started feeling ill on Monday. So guess what? That's where that you start saying that this started. So that was the date of onset. And then with more reporting symptoms on Tuesday and Wednesday. So you're collecting, how many people did that out of the ones that you have. You don't know the lab tests, so you define a sick person. Sick contact. We always ask that. If you've been around any sick contacts, well, there he is. Had to construct that picture. So, you're looking through this. So you have the epi curve that you see at the top, and then it's gone, and it's back. And then the number of people that got sick every day. Obviously, you're not going to send this out. This is just for you because what you're going to do at the end of it is put, this outbreak of whatever it is, which you don't know yet, that occurred at this function associated with, it sounds like it's foodborne. So you're going to have to fix some of this, but this is going to stay. I think people became sick and the number of people who were sick. So now you're getting additional interviews. You calculate the attack rate and the relative risk of the conference events and of each menu item from the welcome party. You can kind of see that at the top. So what do you see? There's three things that kind of stick out. There was a veggie lasagna, sweet and sour meatballs, chicken tenders, and spinach dip. Sounds like a usual kind of conference thing. So it's the number of sick and the number of well in the total. So when you're looking at each one of these, you can calculate the attack rate, right? You got the number of people, the total number of people who are there, and the number of people who are sick, and you look at that as percent, and it shows you the attack rate. Well, this is the number of people who ate an item, the number of people who didn't eat an item, and you can see the attack rate for the veggie lasagna was completely different. The people who ate it and the people who didn't, it's less than 10%. So that suggests maybe that the sweet and sour meatballs was only 11% of the people who ate it, and who didn't eat it was 54%. So that, no, it doesn't sound right. Something else is going on. People who got sick and did that. Chicken tenders, 30 versus 43. And the spinach dip was 82% in this group and 13%. So the ones that really kind of stick out to you are the veggie lasagna and the spinach dip, right? So those are the ones that are making us more interested. And then you're looking at the risk. And it's basically the risk of one group, if you will, group A, and the risk of all the other groups. So you're looking at comparing all these, finding out that the relative risk is going to be with the veggie lasagna or the spinach dip. So trying to figure out which one of these maybe isn't. It's not clear yet. So now you know what's going on with that. And the bottom just tells you a relative risk greater than 1 indicates people exposed had a greater chance of getting sick than those who weren't. So that there were some, the chicken tenders, but it's not that high. This is how. So it's these two. So what do you think the likely source of the outbreak is? Chicken tenders? Survey says, Spinach dip? Maybe. But do we know that for sure? No, not yet. So it could be more than one. So we narrowed it down to two, right? Could be the veggie lasagna. So is there a commonality between those two? You start looking, so now it comes back that it's an E. coli 0157. The health department is confirming the results, but it could take several days. So now you ask the caterer for all the receipts from the welcome party and review the ingredients. So you see the two dishes with the highest as relative risk, the spinach dip and the veggie lasagna, both had raw spinach leaves added as a garnish after the dish was cooked. So now there's a commonality. So you start looking at this and there's nothing else. You call the FDA to let them know that, hey, you've got an outbreak and this is what you found so far. And you need to let them know, because are you going to call, try and find out who grew the spinach and say, hey, guess what you got in it? And you better recall it all right now. And they're going to laugh at you and say, who the hell are you? I'm an ID expert. Okay. And we're going to do exactly what you say, bow down to you. No, you have no authority to do that. So you don't have any time. So you go visit the caterer, not the people who grew the spinach, and you find some unopened bags of fresh spinach that were purchased at the same time as the other ones. Since it's still in the bag, the FDA is able, you don't do it yourself, but you give it to the FDA, and there's always local ones. There's an FDA in town. So you give it to them and they can trace the lot numbers back to where did it come from. And that's what they do with all these outbreaks. If they can find something like that and then track it back to where did it come from. So what do you do next in the investigation? You take the leftover spinach and contact the spinach producer. Do you recommend a recall? You send an advisory about E. coli infections linked to spinach out to the media. So that's what you do next in the investigation. And then what did you do next? Do you shut down the production facility when the spinach was packaged? Good luck with that. Ask the FDA to contact the producer to suggest a voluntary recall and determine if the 12 people, if the 12 people also ate spinach. Well, I think we figured out that, you know, it probably that was the major thing, and it was involved with two things, just the spinach itself and then with the vegetable science. So realistically, you know, what do you want to do next? Well, you took it and you go ahead and contact the spinach producer and to say, there's an outbreak going on. We're concerned it could be, you know, the spinach. And you can also tell them that, you know, we're working with the FDA on this, and also the county health or the state health department that's asked me to look into this. So as a courtesy, we're giving you this so you can burn all your records and say we never grew spinach in the first place, whatever. They're not going to do that. So you got to rule out things like cross-contamination in the kitchen, you know, where they're chopping stuff up, which has happened in the past. The spinach is to blame, then it's going to be the health department, the FDA are going to be the ones to take care of it, not you. You've helped identify what's going on, and now you can back out because you don't have the authority to really have people do things. So clue number 4, the results are in, and it shows the sick people are all infected with E. coli 015787. And since they didn't go to a petting zoo or anything else at this veterinary thing, it probably got the food. So somebody, and this has happened before, it actually happened with cantaloupe. Many, many years ago, I have a sister-in-law who's retired now, but used to work in enterics at CDC, and she would always call me and say, hey, they're going to present this case at IDSA, you should go, because the one that she was talking about was salmonella with the species name of Chester. And I'd never heard of salmonella Chester. She goes, yeah, you should go. It's interesting. It was an outbreak that really got light because it involved some other people, but it happened on an airplane with catered food that came into the airplane, and it got tracked back to the cantaloupe. And it's funny when CDC presents things, they do have a sense of humor. And on the slide, they had a picture of the airplane and had it as airplane A, but of course it was a Delta on the back of it, so you knew what it was. And what happened was that it was preparation of the cantaloupe, you know, they're peeling the cantaloupe to get the rind off of it. Well, they didn't really wipe down the area after each one. And when they looked at it, the number of people that got sick was from cantaloupe that were grown actually in Mexico. And when they went back and looked at the farm where that they were actually from, they found out that sanitation in the fields was not great. You know, I mean, the push is on to get as many as you can. So if you're going to take a bathroom break, you're out in the field. So you just do it there. And so that ended up giving them this strain of salmonella. Well, anyway, so it was 3/4 of the United States that got this. Southeast didn't get it. Why? We got our cantaloupe from Guatemala. So we didn't get any of that. So we dodged that bullet. It was a really interesting way that they've gone back and do the epidemiology. So now you're talking to them, sending this, the DNA, the PulseNet, which will then look at their, if you will, since they do total sequencing on these things and look at this strain, and they find out that this is a new one, interestingly enough. So they're really interested now in, okay, where did it come from and what's going on? So that's what they want to look and see. So you know now that there's other investigations going on in other states from this, besides the one that you're involved with, which you can kind of sit back and say, isn't that interesting? I was part of this and I helped them. And so there was 2 cases in California, 25 of those that you found in Georgia, Missouri had 2, Tennessee had 5, Utah had 3. So that's what was going on. And the last question is, am I ever going to need to know this? Yeah, you are. This happened to us here, not in this hospital, but in the old one, 2015. And several of us were involved in that. We had in July, starting around July 4th, when everybody kind of wanted to get out of the hospital, so there were open beds, and they were moving people around, trying to clean rooms and stuff, because the census was down. And there was a patient who had influenza. I didn't know that. I didn't pick it up, but Dr. Ayler's wife did. And she calls me and says, I got this patient who's got the flu. I said, how do you know? And she said, he's in a 4-bed room. He's coughing and hacking. And so, you know, they got upset. The other 3 people said, you know, you need to talk to this guy. Well, he had a friend at home who supposedly was sick from the flu. So he got tested. He's got H3N2. Is this H3N2? I can't remember. I have to look and see. Yeah, it's H3N2. And so by then moving people around the hospital, it travels around the hospital. So as this started out with few people being exposed because of the movement in the hospital, that's what you saw. And you really need to set up a grid and start looking at this. I mean, this is what we looked at: age, sex, ward, admit, transfer, symptom onset, flu test day, flu results, prior IIV date, when did I get vaccinated, and comments. We had not only patients, but we had fellows, we had residents, we had attendants getting involved in it. So I called the state epidemiologist. I said, do you have an outbreak of flu anywhere? And she goes, no, it's the wrong time of year. Hence the title. Wrong place, wrong time, wrong place. She had no idea. And I called down to Hillsborough County and said, we had an outbreak. No, you don't. Yeah, I do. And so we did get it under control. We had to get into the cache to get oseltamivir to prophy people and to treat people, because guess what? It's in the middle of summer. It's the wrong time for us. If it's the wrong time for us to have flu, when is it the right time to have flu? It depends on where you are. If you're in South America, that's your winter. And do people travel? Yes. Do people travel sick? Yes. Do people get in cruise ships and swear on the form that they are not sick and going, yes, I'm not sick, because they didn't get insurance and they're going to lose their money. So they travel sick. And that's what we have to be conscious of, is just because it's influenza season now here, you know, people may be elsewhere bringing things that are more common in the summer back for us if they travel. So always remember to ask if they've had any recent travel or anything.
And another facet of the story is a lot of times your flu vaccine will expire
Yes, and it was
in the
gone.
middle of the summer. So we
Yeah.
had trouble finding flu vaccine to vaccinate people
yeah.
because,
Expires on June 30th.
Yeah.
yeah.
The year stop.
So it was not fun. And I had to call, the only place I could find actually Tamiflu in the area was over in St. Pete. So for, you know, there were employees who got sick, and until we could get into the cache, I was saying, where can I get it? So that's the only place they could get it. So yeah, it was not fun. But you learned a lot from getting into it. And Dr. Hassan would like to put his name on it because he was going crazy trying to track all the stuff. He really enjoyed it. So, you know, just to make sure that, and last year I made a joke that this was Dr. Canella. He paid me back. But this is, I mean, you know, this is what we do. We're the ones that may not be the ones who are out on the front line looking at outbreaks of things, you know, like hemorrhagic fevers or anything else. But it's the same concepts. And when we were worried we were going to get Ebola patients here, we had no idea. We all had to get the training and everything. We have no idea if we'll see anything else because there's other hemorrhagic fever, Marburg is around still. And there are a few other things that we do have to keep watch on. So with that, that's the end of that. And if you have any questions, I'll be happy to try and answer them.